Hello, everyone. My name is Alyssa Suddeth, and this is my AH 563 evidence-based practice paper presentation on whether or not the Thessley test or the McMurray test is better suited for the diagnosis of meniscal tears. So my research question is, in patients suffering from an acute knee injury, does the Thessley test versus McMurray's test accurately diagnose a meniscal tear? So first we're going to talk about what is a meniscus. So there are two menisci per each knee joint. They are semilunar fibrocartilaginous disc. They are located between the medial and lateral articular surfaces of the femur and tibia. And as you can see in this picture on the left, the medial meniscus is more of a C-shaped, while the lateral meniscus is more U-shaped. Also in the picture, you can see that the outer edges of the meniscus are primarily thick and they run thinner as you get to the medial aspect. The outer portions of the meniscus attach to the tibia, while the inner portions move freely due to having no attachments. By having the shape that they have, the menisci are free to move and shape to the forces that they receive. So there are three different sections to a meniscus. You have the anterior horn, the body, and the posterior horn. And it goes just like that. So I don't even know if you can see my mouse, but using this medial meniscus over here, you have the anterior horn, and the body's kind of in the middle, and then the posterior horn. The posterior horn receives the largest portion of the load that's put on the joint, and it also provides the most stability for the joint. So what is the purpose of the menisci? Well, a meniscus only has two roles throughout the joint, and it's absorbing shock and distributing loaded stress. By distributing the loaded stress, it creates a source of protection for the menisci by distributing the forces throughout the entire joint instead of allowing it to fall directly on one portion of the meniscus. So if somebody was placing a lot of pressure on their posterior horn, the posterior horn would deteriorate at a faster pace than the body or the anterior horn. Ooh, let me move my little thingy, I can't see. So meniscal tears or meniscal injuries are one of the most common injuries to the knee. They can be caused by any activity that causes a forceful twist or rotation. They can also happen by kneeling, deep squatting, or lifting heavy items. The medial meniscus is also more susceptible to tear and injury than the lateral meniscus. Medial menisci tears and injuries occur at a ratio of 2-to-1 compared to the lateral meniscus. This is due to the direct attachment to the medial meniscus, of the medial meniscus to the MCL and the joint capsule. And then also, males are 20% more likely to sustain a meniscal injury than females. Oh, okay, we're back. So how is a meniscal tear confirmed and repaired? So you could use special tests like the ones we're testing in this study today, like the McMurray's or Thessley's, and there's plenty others. It's confirmed solely by an MRI. So an MRI is basically the gold standard at this point to confirming a meniscal tear. The surgery that you would have with a meniscal tear is called a knee arthroscopy. And there's about 1 million meniscal surgeries performed in the US each year. So a meniscal surgery or the knee arthroscopy takes about 1 hour, and it only consists of a few incisions throughout the area. The recovery and rehab time is only a few weeks, but not everybody has to have a meniscus tear repaired. It is based on the type of tear, the size and location of the tear, the patient's age and activity level and lifestyle, and if there's any related injuries. So say we have an athlete, well, if you have any athlete, they're probably going to get their meniscus repaired. But say that somebody has an ACL tear along with a meniscus tear. They're probably going to go ahead and repair the meniscus along with the ACL. And it also has to do with symptoms. If it's immense pain, then you'll probably end up having surgery. But for those who don't have the surgery, they are normally prescribed rehab and treatment just to strengthen the joint and try to repair it on its own. So how to perform a Thessley test. And I know you can read this, but I'm going to read through it. So the patient stands on one leg, flat-footed. The clinician will assist the patient by offering support for them to hold on to. The lower extremity is then actively flexed to 5 degrees for the first portion of the test, and then 20 degrees for the second portion. So at this point, you have a patient standing on one leg with the knee flexed to 5 degrees, and you want to start with the uninvolved leg first. The patient, with the support from the clinician, will then rotate medially and laterally 3 times while keeping the desired degree of flexion. The test is then performed on the uninjured lower extremity first, and then repeated on the injured lower extremity. And so after you perform the test at 5 degrees, you will then repeat the test at 20 degrees. A positive test for the Thessley test is if the clinician notes any discomfort along the medial or lateral joint line or any locking sensations of the knee. And I've included a link to see a Thessley test performed here. This is also the same link that I showed to the athletic trainers at UAB to have them perform the test on their athletes. Next, we have a McMurray's test. So once again, I'll read through it. I'm sorry it's so much on one slide. The McMurray's test is performed with the patient supine, so lying on their back. The clinician is at the patient's side, holding the knee, palpating the joint line with the thumb on one side and the fingers on the opposite side. The opposite hand supports the foot so that it can maneuver the lower extremity in various motions. Beginning in maximal flexion, the clinician will extend the knee with movements of internal rotation of the tibia while applying a varus stress to the joint. The joint will then be returned to maximal flexion. The clinician will then extend the knee once again in that starting position, but this time will go with external rotation of the tibia while applying a valgus stress. To further narrow down the location of a tear, an internal rotation of the tibia followed by the extension of the joint will test the posterior horn of the meniscus. So another thing, a mixture of just wanted to add this in because it's not in how to perform the test. So the mixture of internal rotation and varus stress is used to test the lateral meniscus. And while external rotation with a valgus stress is used to test the medial meniscus. When you're performing the McMurray's test, it is difficult to test the anterior horn due to the lack of compression and pressure in the area. A positive finding for McMurray's test is pain elicited from the patient, snapping, clicking, and/or locking palpated along the joint line. And I've also added a video of McMurray's test, which was used to show the UAB athletic trainers precisely what I was looking for. So my methodology, it incorporated the UAB athletic training staff, and this is solely due to the purpose of the fact that I changed my paper topic last minute. So UAB only works with collegiate athletes. So collegiate athletes were the only ones involved in this study. So it was with collegiate athletes with a suspected meniscal tear or an acute knee injury. I put out a chart, a folder with an Excel sheet in the clinic, and it included the age, sex, sport, results for each special test, the playing surface, and the actual MRI results, so that whenever the athletic trainers had an athlete come in and they knew that they were about to do a knee evaluation, if I wasn't present, they could just jot down their findings on the chart, and I would look at it whenever I got back to the clinic. So for my data analysis, the data was found in 2 separate contingency tables. The tables contained diagnostic accuracy, sensitivity, specificity, false negative and false positive rates, positive and negative predictive values, prevalence, and positive and negative likelihood ratios. I added a description of each of those on my paper if any of you need to take a look at that. So my results were very few. There was only a total of 5 patients, and their ages ranged from 19 to 21, and they were all collegiate athletes, as I mentioned before. So there were 3 males, 2 females. 2 of them were contact injuries and 3 were non-contact. And the playing surfaces, there were 3 that were on a turf field, 1 was in the dirt, and 1 was on grass. I keep having to move this little block. There we go. Ooh, go back up. I just added in this slide. It's on my paper, but the McMurray's test results. So our 2x2 contingency table stated that we had 2 true positives and 2 true negatives and 1 false positive. So as you can see here, I don't want to read through all this. I'm just going to tell you the main points. So for the McMurray's test, the diagnostic accuracy was 0.8 or 80%. The sensitivity was 1 or 100%. Specificity was 0.66 repeating or 66.6%. And these are the Thessaly test results. It's the same findings for both. So 2 true positives, 1 false positive, and 2 true negatives. And once again, the diagnostic accuracy was 0.8 or 80%, a sensitivity of 1 or 100%, and a specificity of 0.66 repeating or 66.6%. So I can recall quite a few limitations in this study. It depended on the athletic trainer. Even though I went through and gave a description of the test and gave videos and even performed the test myself exactly how I wanted it performed, maybe not every athletic trainer performed the test the exact same way. Also, when the patients may have been sent off for MRIs, which were immediately after the injury, the radiology technicians may not have been the same. I know that doesn't make much difference, but it could have made a difference if there was a larger study of people. The pain scale was a big thing that I saw as a limitation, due to the fact that these athletes were being immediately brought in or evaluated on the field, and they were most likely already in immense pain. So it would have been difficult to differentiate between the injury pain and pain that is actually being elicited by the special test, and also the sample size. I understand that five athletes is not ideal for a study, but at the time, it's all I had to work with. And that is it. If you have any questions, please feel free to email me at alysasudeth@gmail.com or sudetha@uwa.edu. Thank you.